Let's now talk a little bit about acute decompensated heart failure. We'll talk about it and then drop it. But acute decompensated heart failure is more than your routine heart failure that you're going to see in primary care. These are patients who are really sick and require aggressive management in the ICU. You're looking at a lot of hemodynamics in these patients. You're typically looking at their mean arterial pressure, their heart rate, but you're also trying to indicate, to what degree is their cardiac output and what is their pulmonary capillary wedge pressure, what's their systemic vascular resistance, what's their CVP pressures. You may need a Swan-Ganz catheter for that or other kind of monitoring that's pretty much going to be limited to a, an ICU kind of setting. And even then, not all ICUs are going to necessarily have all of these bells and whistles, depending on how they manage patients. When you look at the patients, though, who are in acute decompensated heart failure, you want to be able to differentiate that from what's the other etiologies for their hemodynamic changes. And the big one that you'd kind of different in your differential might be, are they septic? Or is this heart failure or is this sepsis? In acute decompensated heart failure, whether or not you have a Swan-Ganz where you can measure pulmonary capillary wedge pressure or cardiac output, cardiac index, you can still look at the patient and tell, they have elevated wedge pressures. Well, they're congested. They've elevated fluid overload. You can tell that on physical exam by dyspnea, orthopnea, peripheral edema, rails, ascites even, jugular venous distension is a big one, hepatomegaly, splenomegaly, and then hypoperfusion. What's their cold extremities, changes in mental status, fatigue, organ damage that's suggesting that cardiac output is down as well. I'm hoping that this gets talked about somewhere else in the curriculum as well. It may or may not. But the Forrester hemodynamic subsets are, for the most part, determined by, are they fluid overloaded or not? Do you have a cardiac output or cardiac index that is higher or lower? So where you want patients to be is category 1, that their wedge pressures are low, they're not fluid overloaded, and they're perfusing well, they've got a good cardiac output. We call those folks warm and dry. If their cardiac output is generally pretty good, but they have a lot of pulmonary congestion, we consider them warm and wet. That's category 2. Category 3 is that they're hyperperfused, but they're not fluid overloaded. And category 4, they're crumped. They have pulmonary congestion and hypoperfusion. Important for you to understand or appreciate the patient you've got, particularly if they're hemodynamically in tough shape and look as though they are, in acute decompensated state, because knowing where they are in this, you kind of know what to do. Here's what you do. If they're warm and dry, you just do the guideline-directed medical therapies that they're on. They're good. They're not in your ICU with acute decompensated heart failure if they're warm and dry. If they're warm and wet, diuretics. If they're cold and dry, then you're going to titrate them maybe with a vasopressor or an inotrope, depending on what you need. But they may be candidate for an inotrope. We're going to be really careful about whether we really need to use that or not. And if they're cold and wet, you throw the kitchen sink at them. Okay? But you want to be kind of clear about the outcome measures and titrating, your diuretics when you need them, titrating your the other issues that you need to do with maybe vasodilators if you need them, but also inotropes if you need them. And it's a little bit of a dice game for you to, you do one thing, you're trying to do a little bit of a vasodilator so that you can decrease afterload, but you're overshooting that, and then you have to give them an inotrope. I mean, it's a mess. The pressures won't tolerate it or whatever. So you're careful about how you walk that tightrope. More specificity about what constitutes diuretics, inotrope therapy, and vasodilators are listed here. I encourage you to read through them. Stop the slide, just read through these, get a sense of how you approach that. And for diuretics specifically, we typically look at starting folks on a loop diuretic. You start them with an oral diuretic. If you have to switch them to an IV diuretic, know that the bioavailability of most of the diuretics, particularly furosemide, the common one, the easy thing we look at here is, furosemide, 50% bioavailability of oral furosemide is about 50%. And so if you want to double their furosemide diuretic and they're on 40 milligrams twice a day of oral furosemide, then you're going to double that dose by putting them on 40 milligrams IV furosemide when you bring them in the hospital. You've just, if you're going to keep them on the same dose, then it's 40 oral equals about 20 IV. Okay, so you're kind of watching that. That'll become more familiar to you when you're in practice and doing it. The thiazides make some sense when you're adding a little bit of kick to somebody when they don't get quite the response from loop diuretics. And if they have diuretic resistance, then the guidelines are adding a thiazide diuretic. One I see most often is metolazone. You could use hydrochlorothiazide about 30 minutes before the loop diuretic is given, or a continuous infusion of loop diuretic or both. You're watching electrolytes, particularly potassium and magnesium. You're watching that you don't overshoot getting the fluid off, throwing into dehydration, acute kidney injury, which we talk about that in the renal block. And then other things you might look at is whether or not you need a vasodilator. We use different vasodilators in hypertension. We don't really use IV nitroglycerin that much. We never use nitroprusside in hypertensive crisis. But in the guidelines, we still might find nitroprusside or IV nitroglycerin, probably that's when you're going to use more, in decompensated heart failure when you need a vasodilator to affect preload and afterload in somebody where you're also managing maybe their inotrope therapy at the same time. And there's more in the doses of nitroprusside and nitroglycerin. And then the inotropes, the two main ones are dobutamine, which has more cardiac effect, or milrinone, again, more cardiac effect and more parameters there. Don't get stuck on too much detail here. And then as you think about, all of the vasopressors we have, all the pressors you've got, the sympathomimetics, where do they fall on alpha versus beta? And dobutamine is more beta than alpha. So that's kind of what you want with a cardiac inotrope. Okay, that's it for this. The next section is just going through the 2022 guidelines for which we'll walk through those and then highlight the key areas. Okay, you may have seen some of these slides already elsewhere in the curriculum. You may not have. The full slide deck from the American College of Cardiology and the American Heart Association, which were published in 2022, are posted also online that you can look at more specifically. There are lots of them here. I'll try not to belabor points here. Let's just walk through them, and I'll speed up or slow down as I think that's something pivotal related to therapeutics. It's all important, but let's go to what I think I'd like to emphasize from my perspective. So the citations here, top 10 messages, they say top take-homes they start off with, but then they go into a little more granular depth, a lot more granular depth. We'll go through that. So one is, this is big, guideline-directed medical therapy for heart failure with reduced ejection fraction includes 4 med classes, which includes the sodium glucose transporter 2 inhibitors. That's new. That's big. That's new. That's a big deal. We'll talk about where those fit as we look at the algorithms in a bit. They recommend also SGLT2s for even mild reduced ejection fraction patients. And in those patients, they also still recommend angiotensin receptor blockers with an iprilizin inhibitor or an ACE or an ARB and or a aldosterone receptor antagonist and beta blockers. They still recommend all of that. But the first thing they're saying is that if it's mild, the longitudinal data is looking like the SGLT2s have a number of things that can forestall or delay the development of heart failure more so maybe than the others even do. The other recommendations that we look at are SGLT2s and the other therapies are sort of integrated in the management of everything else as well. So they make recommendations about don't forget to manage their hypertension, their AFib, their hyperlipidemias, their all of it. Okay, so they think that's, they kind of recommend take a holistic view of your patient. Other things look at how they've defined reduced ejection fraction now. They've got a new category, mild reduced ejection fraction versus reduced ejection fraction. So the magic cutoff number is 40%, but they kind of look at folks who are sort of in the 40 to 50% as more mild, and their recommendations are subtly different for them than they might be for folks who have a more reduced ejection fraction. They also make a number of value statements, and these have to do with the expensive therapies. So they recognize that while they make recommendations for nepralizin inhibitor ARB as a first line over ARBs alone, while they make recommendations for SGLT2s, they also make some comment in recognizing if a clinician is stuck with not being able to have a patient afford or have access to some of these therapies, then the next best thing might be do this. They recognize that, but also recognize that it is a two-tiered healthcare system that really they don't like to have to do that, but they do. They talk a bit about amyloid heart disease. I'm not going to go into that. They talk about other factors, thinking about filling pressures and evidence and invasive versus non-invasive testing. I'm not going to go into this as well. Advanced heart failure is its own thing, and when you get to palliative care or figure out who's a candidate for that, usually going to have specialists in that field. They also look at primary prevention, and the big issues here are to look at all of the cardiovascular health benefits that are evolving, to do all the diet, exercise, lifestyle things you can, but the addition of the SGLT2 inhibitors just really is a mainstay, what's looking like it may be in the primary prevention category or maybe early secondary prevention. Finally, all of the other comorbid states that they recommend paying attention to. They indicate their levels of evidence and the quality of that evidence. So even as you're looking at the guidelines, they color code it, which is nice. They color code green as those strength of evidence and the quality of evidence in the blue shading. Green is strong evidence. Yellow, less so. Orange, less so. When you get down to red, there's really harm associated with that intervention. So really what you're trying to look at is what are some of the stronger recommendations they make, and how what's the quality of that evidence. So when you look at the graphics and the slides, it's easy to kind of pick that out. Okay, definitions of heart failure. We've kind of talked to that already. I'll leave that for you here. Stage A, B, C, and D are at risk for heart failure, pre-heart failure, symptomatic, and advanced heart failure. They talk about trajectories for heart failure. I'll defer you to sort of look at that. I encourage you to really pay attention to these so you have an appreciation for how heart failure evolves for many patients. And then they defined this with a new class now. This is new in the guidelines. It wasn't the case. If your EF is between 41 and 49%, you are now in a mildly reduced EF category, as opposed to greater than 50%, you're in a preserved EF category. And then they look at how folks may transition from one category to another. And so important to kind of an appreciation for how the patient's doing. Were they poor and are getting better, improving? And they recognize that in this first top of the slide, where they went from below 40 to above 40, they recognize that they're improving. And that's important to keep up what's worked with them and keep them from going below 40 again. They also have an algorithm for diagnosis. I'm going to defer you to the ClinMed discussion there. They also have lots of recommendations for initial and serial evaluations. Slides about how to sort of on physical assessment, things to look at, and looking at their history, and the physical exam should help in how you evaluate patients. More on history and physical. Keeping in mind the non-ischemic causes for heart failure, which include chemotherapy and other drugs. So you want to make sure that's the case. You want to think about what other kind of processes have gone on that contribute to the patient's heart failure. They make recommendations about lab and EKG testing for patients. They make recommendations on prevention, initial diagnosis, and risk stratification for these individuals, looking at also the measurement of markers, BP and BNP, and terminal pro BNPs as well. They also look at other sort of factors related to how the biomarkers relate to that. They look at potential causes for elevated and BNP levels. So these are things that might elevate BNP and not be just heart failure alone. They look at non-cardiac as well as cardiac elevations in natriuretic peptide levels. They recommend about genetic evaluation and testing. Recommendations about imaging. More about imaging. More about imaging. Exercise and functional capacity testing. And finally, let's go to staging. So patients at risk for heart failure, they make some recommendations that you do all of the standard things that you're doing. You're managing their blood pressure, their lipids, you're doing type 2 diabetes assessments, you're looking at their cardiovascular risk factors. And for anybody, particularly if they have diabetes, you want to look at an SGLT2 inhibitor if they're at all looking like they're at risk for heart failure. They're also looking at other lifestyle things that you want to push for patients, and then they talk a bit about the role of biomarkers in this cohort. The bottom line here is at risk for heart failure, the only thing they're recommending as far as drug therapy goes are the SGLT2s. But if the patient has hypertension, likely you are going to pick an ACE or an ARB. Unless it's a woman of childbearing age, or they have a contraindication to an ACE or an ARB, like angioedema or something else. Maybe even renal artery stenosis if you happen to know that. Okay, but the rest of their management, you're going to do all of the optimal management for coronary cardiac vascular disease. So you're doing the statins. You're looking at their history for any cardiotoxic drugs, particularly if they have rounds of chemotherapy. And then you want to look at any genetic or family history that leads you to make some thinking with them. If you think they are early of higher risk, they're earlier stage B, then you may want to look at making sure they're on an ACE or an ARB, or an ACE or an ARB with an aprilin inhibitor and a beta blocker. So you want to kind of check on that. But ACEs and ARBs and or aprilin inhibitors are going to come in pretty quickly. Now this one looks just that ACEs and ARBs doesn't look at aprilin inhibitors yet when you're talking about stage B. So there are the guidelines pretty much for stage B. They look at ACEs or ARBs are generally in stage B individuals. And they're also looking at all of the other sort of factors in assessing these patients, making sure they're on statins and doing the goal-directed medication interventions that make sense. Where you start to look at more aggressive management are the stage C heart failure patients. These individuals are always going to be juggling a number of things. Usually, by the time they have heart failure, they're dealing with other comorbid situations as well. And then you're looking at all the barriers to self-care, all of the risks for past and or future hospitalizations. You're looking at making sure the resources are there or trying to assess that for them. And then you're looking at making sure they understand their disease process, their health literacy issues to the extent you can, and they have the kind of supports they need. You want to make sure they're vaccinated against pneumococcal and flu and influenza and COVID, all of the things that make sense. And you need to assess them for social isolation, depression, again, health literacy, the like. There are a number of nice things that they go through here, not nice, but they go through for what are some of the barriers for self-care. And it's kind of nice that they've listed them all out for us because we sometimes forget some of these things. So cognitive impairment, depression, substance abuse, history, overall frailty. They talk about food insecurity, homelessness, if there's some question of elder abuse or partner violence for that patient, what's their language and healthcare proficiency, what's their health literacy, their social isolation, do they have social supports, they have transportation limitations. All of those are going to affect the ability for that individual to really adhere to what are these guideline-directed and goal-directed regimens. They make recommendations about sodium restriction. I was actually kind of surprised this wasn't a green recommendation, but avoiding excessive sodium intake is reasonable. You're not going to get, you got to recognize that you're going to maybe get them from a 10 gram to 15 gram a day sodium diet to maybe a 4 to 6 gram a day sodium diet. And if you can get them down to a 2 gram sodium diet, well, all the power to you, but that's really hard to do. And I think that these guidelines sort of recognize that sodium has a role, but maybe, you can only do so much when patients really are going to have a hard time with the very strict sodium restriction. They recommend activity, exercise, cardiac rehab, and the extent to which you can institute these lifestyle issues, great. They have recommendations for diuretics. Basically, diuretics are added on when you have fluid retention, and then adding a chaser thiazide, like we spoke about earlier, is a possibility when they don't respond to loops alone. Watching their electrolytes. Keep in mind that the diuretics get the fluid off, they improve their comfort, their endurance, they may reduce their risk for hospitalization, but they don't have a mortality benefit like the other drugs do. As you look at the common diuretics, there are some of the ones we talked about with typical doses and maximum doses usually observed. They talk about the renin-angiotensin systems with an ACE or an ARB or an ARB with an atrilisin inhibitor. And for these individuals now, we're talking really group C folks now, they are recommending a receptor blocker with an atrilisin inhibitor is the recommended, that's what's recommended. You want to make sure all of the contraindications we talk about with ACEs and ARBs fall into this group as well because you're giving them an ARB. But you're looking at if they can't, for whatever reason, be managed with an atrilisin inhibitor added to an ARB, then you could go with an ACE or an ARB alone, and that's item 2 here and item 3 here. So, but for the most part, you want to go with an atrilisin inhibitor with an ACE or an ARB for anybody who has category C or D heart failure. They also talk about being careful about how you transition somebody from an ACE or an ARB to an ARB with an atrilisin inhibitor. So you have to be careful about how that's done sequencing. And you want to be careful about not giving any of these agents to someone with a history of angioedema. Beta blockers are also first line with one of the 3 beta blockers that are shown to prove decreased mortality. Those are only bisoprolol, carvedilol, or sustained release metoprolol succinate. And you're really sort of paying attention to that. They also will look at the role of spironolactone as a first-line therapy to reduce morbidity and mortality. The data is actually quite good. If their renal function's good and their potassium's below 5, they are probably a good candidate for spironolactone. So spironolactone, the data is surprisingly good as long as they can tolerate it. You want to be careful, though, about folks who have elevated potassium or poor renal function, particularly if the potassium is above 5.5. That's a point where you kind of say, hey, we need to back off on this and figure out what's going on. So spironolactone really ought to be early on after the ACE-ARB and atrilisin inhibitor, as soon as you can, if they can tolerate it, recognizing full well that you're keeping an eye on their potassium and their renal function. And they're looking at SGLT2s again to reduce risk for hospitalization and reduce cardiovascular mortality, whether or not they have diabetes. They also, though, recognize that they state their value is that it offers an immediate economic value. What they're doing is that's not directed so much to us as providers, that's directed right to insurance companies to have them cover it. Hydralazine and isosorbide really make sense for individuals who are self-identified as African American with class 3 or 4 heart failure, New York Heart Association class 3 or 4. If they're who are receiving, you've maximized their guideline-directed therapy, and then you add this on if you can tolerate it. The issues are you sometimes bump into blood pressures that don't tolerate it, but there's some you're going to do the best you can, but that makes sense to consider that for this cohort. So in summary, they have a nice slide in summary here of the treatment for reduced EF stages 3 and 4. It's a very detailed slide. I enlarged them a bit in the next 3 or 4 slides. For step 1, they look at everybody gets a neprilysin inhibitor ARB or an ACE or an ARB. Everybody gets a beta blocker. Everybody gets a spironolactone. Everybody gets an SGLT2. Everybody gets diuretics if they need them. What you're doing is you're layering these on and you're doing it relatively quickly, we'll talk about how the timing of that usually looks, and we'll look at a study that was published in mid-November, early November 2022 that helps guide us there. Um, uh, but it doesn't necessarily mean that patients are going to tolerate all of them. So, but you're going to lay that out for them. And then depending on if their EF is in better shape or not, if it's below 40% persistently despite all of that, then you go to look at further steps here. One step is if they're African American, look at hydralazine and nitrates as an addition. And then you're also looking at whether or not they are candidates for something else. At that point, they're usually, if their EF is less than 35% and they have a greater than a year survival, then you're kind of looking at, are they candidates for an implanted device of some kind or something? Those are steps that are going to be sort of dictated by the cardiology team and whether or not the device therapy makes sense for them or not. And finally, in refractory cases, you're going to look for patients who might be candidates for either cardiac transplant or palliative care that get a little bit beyond the scope of our discussion today, but to be aware of that. Okay, let's talk about some other things as we wrap this up in the next few minutes. Hopefully we can do that even though we have a fair number of slides ahead. One are other drug treatments they comment on for which there's not a great amount of data. Omega-3 fatty acids, maybe some benefit, not a lot of great data, but maybe a little benefit, probably no harm. You want to watch hyperkalemia in folks who are on renin-angiotensin-aldosterone inhibitors of any kind, and they recommend that you may consider the trial of a potassium binder if you think that they are benefiting from the therapy, but their potassiums aren't doing well. There are things that may worsen heart failure. You should go through these quickly. Primarily, it's the calcium channel blockers that don't offer help. Some of the antiarrhythmics, in diabetes, the glitazones, really we avoid those because of the worsening heart failure. That's pretty common, as well as the DDP4 inhibitors probably aren't beneficial either and may offer some worsening of heart failure for some patients. And then nonsteroidals are agents we're probably going to look at avoiding as well. There's a more thorough list of prescription meds that can exacerbate heart failure listed here. The guideline sequencing and up titration. The recommendations here are to use guideline mediated dosing to achieve target doses, and they go through this pretty carefully. Let's go through a couple of slides here that I think are really going to be helpful for you. But they recommend doing things as frequently as every 1 to 2 weeks. That's pretty aggressive up titration for patients. Let's look at a couple of columns in the next couple of charts. These are commonly used drugs, but then they tell you what are target and maximum doses. And the target dose and or the mean doses achieved in the clinical trials are pretty high. And so what you'll find is that for the most part, whether you're picking an ACE or an ARB, an aprilocin inhibitor, whether you're talking about spironolactone, whether you're talking about SGLT2s, whatever, there's a particular dose you're going to shoot for and keep going up until the patient doesn't tolerate it. Because you really want to improve morbidity and mortality when we know that these are agents that improve them. The next chart shows you again issues for beta blockers. What's the titrated target dose for each of these? And the spironolactone dose that you're shooting for if you're going with isosorbide dinitrate and hydralazine, what doses you shoot for there. Again, you start low, but you kind of try to move up every week or so to get them to see if they can tolerate these doses. Here's and then finally ivermectin and digoxin, like these are not commonly used, but when you could consider them for a subset, what kind of doses they use there. I think this slide is fascinating because to me, this slide, if you look at this concept of the number needed to treat, how many patients do you need to treat to prevent one death? Over the next 36 months, I need to treat 26 patients with an ACE or an ARB before to prevent one death. With the ARB and then a prilocin inhibitor, 27. Now, these aren't perfect because they're based on how the studies are. There's difference in who is included or excluded in the studies. So they're not directly comparable, but they give you kind of an idea of the magnitude of benefit different therapies have. What kind of surprises me, or maybe it shouldn't, is that the beta blockers and the mineralocorticoid receptor antagonists like spironolactone, look at that. I treat 6 patients with spironolactone. I saved one of those 6 patients are living today because I started that therapy 36 months ago. That's pretty dramatic in healthcare to see that kind of mortality benefit. So spironolactone is a great drug. Now, keep in mind, this is a more limited data set than maybe some of the others, so you can't hang your hat on that number, but it's pretty powerful stuff to see this. SGLT2s, we're waiting for more data, but, pretty safe, and it's looking like, again, benefit associated with that. The hydralazine nitrate combo has to do more with the subset of patients that are being treated, and then a smaller sample size probably in those studies. But again, what's helpful to keep in mind is every one of these drug therapies has a morbidity and mortality benefit associated with them, and that's why we pick these drugs over others. That's how they ended up in the guidelines. Okay, in early November 2022, the strong heart failure trial gets published in Lancet. And what is the trial about? Why do I have even a key on this slide? Don't take too much out of this. It's not a huge study, but 1,600 patients, mostly in Africa and Russia, not our cohort, not the United States per se. But they randomized patients with heart failure to either a high-intensity treatment arm or usual care. The high-intensity arm, they were getting half of the optimal dose of heart failure meds while they were still in the hospital. They were the angiotensin receptor blockers, beta blockers, mineralocorticoid receptor antagonists. At week 1 after discharge, they were tested. At week 2, the meds were up titrated to full dose. At week 3, they looked at tolerance and rechecked again in 6 weeks. And they looked at additional safety visits, and they had a lot of support. So the kind of support that was required was a lot of visits and a lot of follow-up phone calls in the high-intensity arm. Here's what they found. All-cause death assessed at 6 months. They were 63 years old was the average age. The mean blood pressure is listed here. The mean EF was 36%. About 16% had an ejection fraction of 50% or greater. They actually had to stop the trial early because the aggressive treatment arm folks did so much better that they felt they needed to publish this and no longer keep people in the usual care arm for ethical reasons. The results in this fairly, moderate-sized trial indicated that there were significantly fewer patients with clinical endpoints in the high-intensity arm compared to the control group. They also had the high-intensity group also had a 16% lower all-cause death and a 26% lower high-end cardiovascular death at 6 months. And that's pretty impressive. That, however, did come at a price. Both the resources to do it, which is pretty hard to do, but also the patients in the high intensity arm had higher degrees of adverse events compared to the usual care arm, usually lower blood pressure, hyperkalemia, or renal impairment, but really no serious differences, significant differences in serious or fatal adverse effects. Iverbrandine, they do have a role for it. It's usually pretty much limited to when you've gotten your maximal goal-directed medication list, including beta blockers at maximal dose, and your rate's above 70 still, then maybe iverbrandine. I'll tell you quite honestly, that's not very many patients because you have a lot of room to go up on beta blocker dosing usually. The role for digoxin, more limited, but it might be considered to decrease hospitalization if you've done maximal dosing of everything else we've talked about so far. Same is true for soluble guanylyl cyclase stimulators. They have a role, but it's somewhat limited. So here are some additional therapies and more or less where they fit based on what the guidelines suggest. There are more recommendations in the full guideline set for ICDs and CRTs. I refer to you on that. And these folks are going to likely be seen by the cardiologist and managed with that. Patients with mildly reduced ejection fraction, recommendations for SGLT2s are listed, as well as other data as well and evidence as well for the full range of therapies we spoke about before. And again, diuretics is needed, SGLT2s, ACEs, ARBs, and also spironolactone. What's kind of interesting here is that a slightly higher level of evidence for the SGLT2s before any of the other cardiac drugs are listed. That kind of surprises people, but we're talking about EFs between 40 and 50% here. For heart failure with individuals who have improving ejection fraction, these are folks who were below 40 and got up above 40, just keeping them on their full goal-directed medication to prevent a relapse is the main focus, even if they become asymptomatic. And then the recommendations with preserved ejection fraction, EF above 50%. For the most part, you're aggressively manage everything else cardiovascular-wise. Hypertension, also diabetes, and giving them sort of the full gamut. You're assessing if there are candidates for SGLT2, but that's indicated that could be beneficial for them, and that could be a consideration, and pretty strong one, actually. And then in considering all the other sort of variables here about who are candidates for what types, with preserved ejection fraction, subsets of patients who may be considered appropriate. So for preserved ejection fraction, everybody gets diuretics, again, if they need them, SGLT2s, and then angiotensin receptor blocker with a neprilysin inhibitor, spironolactone, and/or an ARB if they're not on a neprilysin inhibitor. For stage D heart failure, advanced, they recommend goal-directed therapy, referral for specialty referral in these cases because you really have a lot of decisions to make, including are they candidates for devices, palliative care, cardiac transplant, palliative inotropes, which is a rare circumstance to consider. The role of inotropic support in acute care makes sense, but other than that, inotropic support is evaluated if it's more than bridge therapy, it's going to be pretty limited about who's going to be a candidate for that. If patients are hospitalized with acute decompensated heart failure, well, in these cases, they recommend more or less what we talked about earlier, that you manage their congestion, you look at their perfusion, you assess what quadrant they're in pretty much, and their treatment algorithm is pretty similar to what we already alluded to before. They have common factors which precipitate heart failure in hospitalized patients. Sometimes these other things will throw folks into a more decompensated heart failure situation. Pretty common that we see this in the hospital. And then you want to look at during hospitalization, what do you do? Well, if they're already on goal-directed therapy coming in, you want to do everything you can to keep that running, unless there is some major adverse event that makes you think you're worried about continuing therapy. But you do everything you can to keep it going, and to the extent possible, even expand on that unless there's some other issue that's making it worse. Diuretics in the hospital, they talk about approaches to diuretics while they're hospitalized. You want to be careful about patients who are fluid overloaded or not. If they are, loop diuretics, and you want to be careful about how you manage diuretics with a careful monitoring while you're in the hospital. They talk about peripheral vasodilation therapy, pretty limited in hospitalized patients. They talk about VT prophylaxis, which you're going to do in really any hospitalized patient, but heart failure patients as well. They have recommendations of managing cardiogenic shock, for which we typically look at inotropic support in the short window of time for that, and otherwise there's pretty much managed by the cardiac surgery team for the most part. And then transitions of care, again, alluding to really that trial we just looked at, published in November 2022, about how do you maintain the highest dosing you can for patients, transition them to a setting where they can maintain and continue to escalate their dosing for the highest, getting at the maximal doses they'll tolerate, improving their morbidity and mortality to be able to do that. With comorbidities in heart failure, they also have some guidelines, not too many more slides here. Here are, patients who have certain conditions, hypertension, how you manage that. You're probably going to look at ACEs and ARBs as a first-line therapy when you can. Diabetes, you're going to look at SGLT2, of course. And then the rest of them, the comorbidities, they make recommendations for sort of what to do related to that comorbidity. In special populations, important to look at disparities in vulnerable populations. In this situation, you're thinking about all of the speed bumps there are for every patient with heart failure, and then for the individual in front of you, how does that make their ability to adhere to these therapies even more problematic? So assessing that to the degree that you can and helping avoid those speed bumps. There are a lot of oncology issues, both drugs that cause or are related to cardiomyopathies, either drug-induced or otherwise cancer-related, important, and they walk through some of these situations in this cohort. The role of managing heart failure in pregnancy, you're pretty much going to avoid ACEs and ARBs, of course, but you are otherwise looking at trying to manage that with as much guidance from OB and from cardiology as possible. Finally, and near the end here, are the goals of care. And they outline, in when you get to palliative or supportive care, shared decision-making, end of life, that you pull the right folks in for that. And for the last time in this block, again, the review of how the supplemental content for chronic coronary disease guidelines for late 2023 impact on this topic of heart failure. So the guidelines, as we've alluded to, and the both strength of recommendation, level of evidence. We've talked about most of these slides already, but as you will remember, the role of SGLT2 inhibitors, particularly in heart failure, has been revolutionary. And SGLT2s and GLP-1s also, particularly for patients who have type 2 diabetes, offer a cardiovascular benefit. And so, in general, these are agents that are being layered in, particularly in the state of heart failure, SGLT2 inhibitors. There are the roles in pregnancy here. What you'll find is that in heart failure, the heart failure managements for metoprolol long-acting is considered safe in pregnancy. You can use DIG safely in pregnancy, although we rarely use it for heart failure anymore. It offers a morbidity but not a mortality benefit, and even then, not much. Loop diuretics like furosemide are considered safer in pregnancy as well. And so those are some of the mainstays, but keep in mind that ACEs and ARBs, which are and aldosterone antagonists, which are mainstays in heart failure, are risky in pregnancy. They're considered contraindicated. And so in the situation of heart failure in a woman of childbearing age, particularly if she should be pregnant, that really would warrant cardiology and OBGYN having input into how to best manage that in the safest way possible. As you look at the guidelines, again, for heart failure, how they described heart failure with reduced ejection fraction, mildly reduced ejection fraction, and preserved ejection fraction, again, definition of that, this new mid-category of mildly reduced ejection fraction is a new categorization in the last year or 2 years. And the recommendations, the strength of recommendations, as they allude to in the 2023 guidelines, as you see, patients who have moderately reduced ejection fraction, the role of an SGLT2 is absolute for mildly reduced ejection fraction. And then it does make sense with a lower level of evidence to consider ACEs, ARBs, niprilicin inhibitor as part of that, a spironolactone as a mineralocorticoid receptor antagonist, and a beta blocker as well. But actually, the data is strongest for in mildly reduced ejection fraction for adding one of the SGLT2 inhibitors that is proven in heart failure. For folks who have preserved ejection fraction, again, we're looking at the addition of an SGLT2 and diuretics when there's fluid retention, if any, and then the other treatments are dictated based on cardiovascular and non-cardiovascular comorbidities. So, for example, in preserved ejection fraction, layering on of ACEs, ARBs, would make sense if the patient has another indication for that, hypertension, diabetes, but in preserved ejection heart failure, we wouldn't necessarily add those on board if they didn't have concurrent diabetes, risk of diabetes, or hypertension. And again, the same listing here of drugs in pregnancy risk. Finally, the list of drugs for which on your clinical rotations, we would have some expectation that you'd recognize normal doses, but not as a focus here in this block.